Good morning, good afternoon, good evening, everyone. My name is Nicola Bedlington, former Secretary General of the European Patients Forum, and I have the honour and pleasure to moderate today's Ask the Expert session on heart valve disease. The objective of the session essentially is to explore burning issues and advocacy challenges in the area of heart valve disease with three renowned experts. And we hope you'll glean new knowledge and insights to really support your own advocacy and partnership work moving forward. And as you know from yesterday's session, we want the summit to be as interactive as possible. This is your summit, this is your heart valve disease session. So please do enter any questions, thoughts or comments in the Q&A section on your screen right now during the course of today's conversation. And we'll get to that a little later on in the session. I'm delighted now to introduce you to Professor Philippe Guibarot, Head of Cardiology Research and also the Canada Research Chair on Valvular Heart Disease at the Quebec Lung and Heart Institute, and also Professor at the Department of Medicine at Laval University in Quebec. A warm welcome to you, Philippe.
Thank you very much.
And Professor Rogero de Paulis, Director of Cardiac Surgery Department at the European Hospital in Rome, Italy. Again, Rogero, you're very warmly welcomed.
Thank you. Good afternoon to everyone.
And Dr. Suzanne Wade, Managing Director at the Health Policy Partnership, a health policy research consultancy based in the UK. Hello, Suzanne, and warm welcome to you as well.
Thank you, Nicola. Hello, everyone.
So, to set the scene, I would like to kick off perhaps with Suzanne. It might be argued that heart valve disease is perhaps not as well known as other cardiovascular diseases, and awareness raising remains a really key challenge for all stakeholders, as well as the patient community trying to get their messages across. Tell us a little bit about the Patient's Journey report and the upcoming patient-friendly guide to the new ESC Act's heart valve guidelines. What value can they bring to the heart valve community in raising awareness amongst all stakeholders?
Thank you, Nicola. So, as you alluded to, I think heart valve disease is a little bit forgotten amongst cardiovascular diseases. It's probably less known by many outside of the specialist community. And yet it has been described by many as the next cardiac epidemic. And prevalence is expected to double by 2040 and triple by 2060, due mostly to the aging of the population, but other factors as well. And it's a complex disease because it can manifest in different ways, but the global definition is really that it occurs when one of the four valves of the heart is damaged. The good news is that there are interventions, there's best practice diagnosis and care that has been amply described in clinical guidelines, and both Professors de Paulis and Guibarot will be speaking about this later. But unfortunately, there is a lot of variability both within countries and across countries in terms of the quality of care that people receive. And again, this is due to a lot of factors. But one factor I think is this lack of awareness and of understanding, including on the part of people affected. So my organization was privileged to work with the Global Heart Hub and its Heart Valve Disease Patient Council last year to develop the Heart Valve Patient Journey report that you alluded to. And this is available on the Global Heart Hub website. And the aim was to raise awareness of unmet needs of patients with heart valve disease, and really to point to actions that could be taken at each step of the care pathway to improve outcomes for patients. And our work was multidisciplinary. We worked very closely with a multidisciplinary group of experts, and in fact, Professor de Paulis was one of them. And we also had some patient representatives, and we also consulted very closely with the members of the Heart Valve Disease Patient Council, who really provided some invaluable comments and insights. And I think what was different about this report is that the continuing thread was really that we took a patient lens. So we were trying to look a little bit almost beyond the guidelines and look at each step of the care pathway and what was really important to improve upon or modify from the patient perspective. And just to give you a couple of insights of things that struck me particularly that were maybe unique to heart valve disease, and also that I don't think we would have uncovered in the same way and with the same degree of nuance had we not taken this multidisciplinary approach and again, try to really take this patient lens. So first of all, awareness. I mean, I think anyone working in public health or in health policy always says you have to raise awareness of different conditions. But I think given the fact that heart valve disease is relatively poorly understood and known by many people other than specialists, the need to raise awareness is particularly important. And it's complex because the symptoms of heart valve disease, mimic those of aging. And so many people may be experiencing these symptoms and not be aware of it for many, many years, which of course can compromise their prognosis. And this lack of awareness also translates to the primary care community and GPs, so that often they're unaware of symptoms in their patients and they may miss diagnoses. And this is particularly important in countries like the UK, for example, where the GP is the patient's first port of call. And also, to add a layer of complexity, sometimes heart valve disease is completely asymptomatic and doesn't manifest with any symptoms at all. So what needs to be done? Raising awareness of heart valve disease amongst the primary care community, but also among people at risk, so namely people above a certain age, is incredibly important. The message that you should really consult your physician if symptoms appear. But also for those who do present with possible symptoms, a simple auscultation by stethoscope can be a very important first step. But rates of auscultation are very variable across Europe, and arguably every single person over the age of 65 should automatically be tested for a heart murmur by stethoscope when they go see their GP. This could really make a big difference. Treatment, I mentioned earlier that there is effective treatment, and the mainstay for in terms of treatment is heart valve replacement or repair, and I'm sure that Ugero and Philippe will speak about this later. But the timing of these interventions is really important and depends on a number of factors. So the state of damage to the heart valve, but also individual frailty, their readiness for an intervention, their ability to recover, and their personal preferences are very important as well. And interventions can involve surgical intervention or some less invasive approaches, namely transcatheter approaches or TAVI. But the thing is that if a patient presents to a cardiologist and is at that time, for whatever reason, not deemed ready or eligible for an intervention, then they're put on active surveillance and given medication to alleviate symptoms. But this doesn't necessarily affect the progression of the disease. So a watch and wait approach is needed, where the patient is seen at regular reviews and, for example, given an echocardiogram to see if the heart valve has deteriorated further. But the problem is that if a patient is not aware of what the symptoms are of potential deterioration, their condition could deteriorate in between, for example, their 6-monthly exams without them necessarily knowing it. And maybe by the time they present to their doctor the next time at their 6-monthly visit, they've sort of passed the window of opportunity for that intervention. And this brings me on really nicely to another project that we've been working on, which has been the development of patient-friendly guide to guidelines. And what we've tried to do is really, as the name entails, develop a patient-friendly version of recently updated guidelines by the European Society of Cardiology and the European Association for Cardiovascular Surgery. And why we've developed this is, again, because taking a personalized approach, an individualized approach, which marries, if you like, a combination of individual preferences, goals, patient and physicians' perceptions on what's best for the patient, and obviously clinical evidence is super important. And this shared decision-making is written into the guidelines as really a very, very important part of patient care. But it doesn't always happen for various reasons. So with this patient guide, we want to empower people with heart valve disease to recognize those key moments for shared decision-making and try to really actively engage in shared decision-making with their physician. And to your final question, what these what these different documents can bring. I think ultimately they're a step in the right direction to try to help more patients have optimal care. And I think they have value for patients themselves to empower them to understand their condition and also what they should expect from their care, and to try to really educate and empower them to speak to their physicians and try to make sure they receive the best care for them. And hopefully, I think also for physicians, it allows them to maybe take a step back from individual patient care and look at what could be improved system-wide. And then finally, the value is to policymakers who are faced with many, many competing demands, and to try to point them in the right direction of what changes could really make a difference to the lives of hundreds of thousands of people and improve their outcomes in the future.
Fantastic, Suzanne, and thank you for giving us that very clear overview, also highlighting the complexity of the disease itself and the awareness raising needed across the board, including patients themselves that may be unaware of the symptoms that they have, and the value of the report at individual patient level, but also collective level. I guess the heart valve community can come together, as the Heart Valve Council is doing, to really drive change on the advocacy side of things. Thank you. I'll come back in a few minutes to this whole question of shared decision making, because that's a really, really important one. Moving to you, Ruggero, you are and have been heavily involved in both initiatives that Suzanne mentioned. From your perspective and as a leading expert, what progress do you see following the publication of the Patient's Journey report exactly a year ago? What impact has it had from your lens, and how could it have more perhaps moving forward?
Thank you, Nicole. Thank you for having me here. And first, I would like to congratulate with Suzanne for an excellent presentation, but also for the excellent work she has been doing with us in finalize this patient journey. This has been an incredible amount of work. And this, as you just pointed out, is very important that we try to make the most out of this. If I have to say what really was the impact, for me it's difficult to say, because the impact in Europe I couldn't check too much, because for this travel restriction I've been traveling much less as in the past. I used to travel in Europe quite a lot, so I could have checked in several countries. But as regarding to my own country, the impact, I would say, is low due to the fact that we did not translate. We are working on a translation because we need to translate this patient journey in every language. Because as you know, this patient needs to have in their own language. English is good for us as a scientific language, but we need, if you want to reach the patient, we need to give in their own language in a simple term, I would say. So the work I've been doing in excellence. So we really have to improve the way we deliver this to each country. How can we deliver is the second point. Of course, we have to go through all kinds of association, but in order to get as much as people, we probably have to go at the media level, If you think nowadays, how many transmission TV show every day are done about COVID, so everyone is now an expert on virology, immunology. People have learned a lot, thanks in a certain way, thanks to the pandemic. So we have to also use the media also to make people know this kind of the patient journey, because it's very important. This kind of knowledge will reach as much people as possible. So I think we have to, in order to understand the difference, we can compare patient with the cancer disease. For instance, patients that have a cancer, usually they know already, the moment they get the diagnosis, they go to a specific center, so cancer center already well organized. The second things, they are not afraid of surgery, for instance. For them, receiving surgery for a patient having a cancer is good things. While, for instance, they do have fear of going heart surgery, probably because in the past. So awareness of this has to change the mind in the people. Just to explain that receiving heart surgery is not so dangerous. The mortality is very low, and the long-term results are very good. So these two the combination two we should revert, and that's why we have to increase the awareness and the distribution of this patient journal across as much as people as possible. So disseminating the knowledge, as Suzanne pointed out, is very, very important, because patients are often asymptomatic and they think they are well, even they don't know the disease they have. So this is really what we have to do in the next year.
Thank you, and highlighting the importance of the patient's journey report in individual national languages, the accessibility, making sure that it's as accessible as possible to a wide range. And distribution. Because it's an excellent
work, we have to take out the most of it.
Yeah, and the media, the role of media, I think is absolutely key here. Also, perhaps thinking about the COVID-19 environment, the interest and the I guess the desire for ordinary people to know more about issues like COVID-19 could spread into this arena as well, this whole area of self-management and knowing more. Yeah, very interesting. So thinking about the newly published guidelines that Susanna also actually highlighted as well, how do you think that these may improve outcomes for patients living with heart valve disease in Italy and more widely in the European region? What could the impact be?
Yeah, the new guideline, of course, we need to, as well as with the patient journal, we should try to include them in the distribution and to increase awareness of people. Of course, in this new guideline, we highlight several aspects. Now, in order to summarize, I will try to focus on the main point. The first one, we point out on the role of a heart team or heart valve clinic. And this is an important point, because nowadays, diagnosis of heart disease are made in the territory by GPIs, and not always the patient receive the right information. That's why it's very important a second level of diagnostic place, like a heart valve clinic, where there are all the competence are together. So in the new guideline, we really stress the role of a heart team, heart valve clinic in the management of people with heart valve disease, because that makes a huge difference, not only in the diagnosis, but also in the choice of the right therapy. And this is the first point. The second point that is also important, in this new guideline, there has been the indication for surgery are much earlier than previously. And this is due to the fact that we know that the mortality is low, the long-term results are good, so we wait less period. The watch and wait period is being reduced, and this can apply to all kinds of disease. For instance, in aortic regurgitation, people that have a leaking aortic valve, we indicate surgery when the ventricle is smaller than before, so in an earlier stage. And the same we can say for aortic stenosis. We don't wait until the patient is really symptomatic, so he has dyspnea or other kind of symptoms. For mitral regurgitation is the same. Mitral regurgitation is always asymptomatic for a long time. So it's very important that nowadays we refer this patient to surgery much earlier than before, because they know that the results are good, mortality is very low, long-term results are excellent. Even for the tricuspid valve, a neglected valve, we now know very well that if you act at the right time, we avoid a lot of problem later on. So all these aspects are being highlighted in the recent guideline. And so we need to summarize, especially what is new in the guideline, and give them to the patient association, and along with the patient journey, we are preparing this, and this is very important too.
Great, thank you very much. And clearly the value of this heart team working in a multidisciplinary way will bring huge value, as indeed this idea of earlier intervention based on knowledge, based on data that's been collected over the years. Fantastic.
Especially considering the new technology that is now coming. So in order to choose between surgery and new technology, the level of expertise that is required is much more. That's why it's much more evident that we need to go to the place where all aspects of this treatment are available: surgery and transcatheter technology and new imaging.
Terrific. Thank you very much. Turning now to you, Philippe. You're based in Canada. Could you share with us some of the work that's been undertaken there, particularly in the context of the new Canadian patient journey report, in which you were, of course, very much involved? What are the similarities and differences in terms of challenges, approaches, and solutions compared to Europe? And what are the next steps for the report?
Yes, thank you, Nicola. So I think, the similarities is that what Suzanne was referring to earlier, heart valve disease is the next pandemic in cardiovascular disease, and not only in Europe, but elsewhere as well. And in Canada, it certainly will be impacted very much because, our population is aging, and the prevalence of valvular heart disease is increasing exponentially. And so we do not have any pharmacotherapeutic treatment, any drug to slow the valvular disease. But we do have very efficient intervention, surgical or transcatheter, that Ruggiero just mentioned. And however, and unfortunately, too many patients receive this life-saving treatment too late. And this is due to a combination of low awareness, deficiencies in detection, and delays in diagnosis and access to care. And Suzanne very well described this major gaps in the care of patients with heart valve disease. And so in response to these gaps, we with Heart Valve Voice Canada, which is a patient advocacy organization, as you know, and also with the great help of Health Policy Partnership, we developed a Canadian report on the describing the optimal care journey for people with valvular heart disease. And actually, this report builds on the European report published by the Global Heart Hub in 2020 that Suzanne described previously in this session. And we actually adapted it to Canada. We did some additions, some changes, some specificity to Canada. And it was developed under the guidance of a multidisciplinary advisory council, which included people with lived experience, of course, and also healthcare professionals engaged in heart valve disease in Canada. And I think, of course, we did a state of the art. And we identified several major needs and gaps. But on what I would like to insist more is what we need to change and the recommendation and call to action that we did in this report. And several of these actions and recommendations are very similar to the European report. I think Suzanne mentioned awareness. This is extremely important. And this is awareness, of course, for patient with valvular disease, for healthcare professional, but it needs to touch first, I think, awareness in the general population and for the policymakers, because, the people in general, they know about cancer, they know about cardiovascular disease such as heart attack, stroke, but valvular heart disease are under recognized, they are under the radar, and we need to change that. This is the start of everything. Also, we believe that there needs to be some support from the government for patient organization. I think that this is something that maybe was not emphasized enough in the European report. We need to have public funding provided for patient organization in order to ensure delivery of ongoing support and information to the patient, the families, and the caregivers. Clearly, there are deficiencies in detection. There is a report in UK, a survey, suggesting that 2/3 of the patient, and it's probably the same in Canada or even worse, 2/3 of the patient with significant valvular disease, we're not talking about mild, moderate or severe, they're actually not detected. They don't know they have valvular disease. And of course, if you don't know you have valvular disease, you're going to be treated too late. And so this is extremely important. We need systematic auscultation. In the European report was mentioned over 65. We've been more let's say, aggressive. And we said every Canadian over 60 or with a pre-existing valve condition should receive annual auscultation by stethoscope as part of the routine checkup. And we put a date for that by 2025. We would like this to be accomplished by 2025. We realize it's ambitious because in Canada, we have a problem with regard to access to primary care. It's not every Canadian who have access to primary care. So that's, of course, we need to solve this issue first if we want to have a systematic auscultation. And of course, there is, and this was mentioned, and there is a big inequity and disparity depending on where you live. The rural areas, the First Nations are underserved for this, even more than the general population. The other thing, of course, diagnosis via echocardiogram. I think the echo is really the key modality to make the diagnosis and follow the valvular disease. We need rapid referral. And in Canada, the waiting list to get an echo is quite long, is too long, even worse, of course, with the COVID. So we made this recommendation that echo should be offered to symptomatic patients within 2 weeks of initial referral, and to asymptomatic patients, so those who have no symptoms and do not complain of everything, within 6 weeks. And this should be accomplished ideally by before 2025. Also, we need the provincial government, because the healthcare system in Canada is the prerogative of the provincial government, to invest more, to have more professionals and specialists able to perform high quality echocardiogram. And also we need to standardize the reporting of the echo, because it's one thing to do the echo, and then it's another thing to report the right information in a standardized manner and clear manner to the referring physician. And we have to do some improvement too in this regard. Then, of course, when you have the diagnosis, I would say it's the beginning of the patient journey. And we need to have the patient needs to be taken in charge, to be managed by a dedicated structure and team, by a dedicated service, ideally a heart valve clinic. Ruggiero mentioned this. I think the heart valve clinic is critical. If it's not a heart valve clinic, whatever, it needs to be a dedicated service that is gonna follow the patient by physical examination, by echocardiography, and will not have a regular discussion with the patient to establish a care plan. And this is extremely important. And the patient, they need a clear point of contact. Absolutely. In Canada, often they when they have eventually they want to have a follow-up, or they have some new symptoms, they don't know exactly who to call and when. So we need a centralized point of contact for that. That's some of the recommendations.
Yeah, no, that's really, really helpful. And that is the essence of person-centered care. It's interesting that you highlight that the European Patient Journey Report acted very much as an inspiration for the Canadian report. Absolutely. And I think that shared learning and collaboration at global level is so important. The support for patient organizations, again, public support for patient organizations to play their role, not only as service providers, providing information, quality information to patients, but also as advocates is really key. And I liked your way of actually your call to action within the journey, within the patient journey report, stipulating clear timeframes. We want this by 2025. We want this within 6 weeks of diagnosis. All of this is really critical in terms of moving the needle for heart valve disease patients. Let's just quickly go back, Philippe, to the recently published guidelines that we've talked about with Philip and Rogero. In your view, how will that impact also on the heart valve disease patients in Canada? How will these improve outcomes, and how can the new Canadian Patient Journey Report work in sync with these guidelines to move the agenda? Any thoughts on that briefly?
Yes, so what I like in the American guidelines as well as in the European guidelines is that there is more emphasis on shared decision-making. And I think this is one of the key, and this is one of, I think, the component that will help to advance and improve the patient journey. but it needs to be, again, true shared decision-making. And here, of course, the heart valve clinic has a role because this is the service that will follow the patient through the entire journey and will eventually refer the patient to the heart team when come the time of intervention. And of course, the shared decision involve the heart team. But the role of the heart team is more punctual, and the guidelines insist also on the role of the heart team, that they are those who, or this group of experts, of multidisciplinary experts, that will eventually identify which is the best therapy for the patient at the right time. And of course, this decision needs to be taken in close communication and a synergy with the patient and the family and the caregivers. I think we have also to take into account the environment of the patient. But the number one in the decision is and still should be the patient. Okay, so that's extremely important, and this is well emphasized now in the guidelines. Before in the guidelines you had like, well, if there is this and this in this criteria, this is a class 1 or class 2 indication for valve replacement or valve repair. But now you have the patient preferences that are included in the choice of the timing and type of intervention. And I like this, and this is extremely important. Yeah. The other thing that Rogero well mentioned is the timing of intervention. We feel that, as the edition of the guidelines is advancing, you have more and more evidence and more recommendation for earlier intervention, because we realize that if we wait too long with severe valvular disease, the patient will have sequelae, and even if the intervention is successful, even if the surgery is a great success and the device is working well, the prosthesis is working well, the patient may not go back to normal because we have intervened too late in the course of the disease. So there is a kind of a trend at the present time to intervene earlier and earlier. And that's why this is so important to also detect the disease earlier and earlier. Because if you detect too late, of course you're going to treat too late. That's why, I think this recommendation of earlier intervention provides some fuel to support, our recommendation of earlier detection, close follow-up in a dedicated structure, because it's only this dedicated structure and service, such as a heart valve clinic, that will identify, oh, okay, now this patient has progressed to CVAS, and even if there is no symptom, it's maybe the time to consider earlier intervention. So that's another very important, I think, aspect. And of course, the other thing is, in the guidelines, there are now recommendations for the new technologies, transcatheter, TAVI, transcatheter edge-to-edge repair, that I think is a good alternative to surgery for some patients, not all. And the guidelines have provided some guidance into how to select the patient for those new technologies. But this access and the timely uptake of innovative and evidence-based technologies is something that we have emphasized in our patient journey, and that is also emphasized in the guidelines.
Great, thank you very much. And again, this idea of patient preferences, patients' goals being central, this is a major cultural shift. The use of new technology, the innovations, and of course, health data supporting all of this is also, I think, absolutely key. So thank you very much. I think we've had a fantastic overview from our three experts, and we're now going to open up for questions. We've had a few comments and questions in so far. First of all, somebody who was diagnosed at 73 with heart valve disease made the comment that in the 30s, many years ago, she had a heart murmur as a child, but that wasn't properly identified. If that had been identified then, this would have had a massive impact on her quality of life. Another person from the UK is remarking the impact of the patient journey report in the UK led clearly to major differences in improvements in national guidelines. I'm going to kick off with a first question. What do you see as the role of patients at individual and collective level in advocating for the implementation of tools like the patient journey report and the new guidelines? What difference can patients themselves make at individual and collective level? We've, of course, touched upon this a little during the conversation, but can you perhaps delve a little deeper? And I'd kick off with Suzanne on this one.
Thank you, Nicola. And I just wanted to thank Philippe and Ruggiero for the really interesting presentations as well. I think and this is a very big generalization and it depends on each country, but I think if you look at the role of patient advocacy in sort of standing up for best practice and access to care in cardiovascular disease generally, compared to cancer, or I know when we always compare to cancer, but cancer or other areas, I don't think it's strong enough. And I think maybe particularly for heart valve disease, again, for the reasons that we've stated, again, there's the beginning and you know, the Patient Council and the Global Heart Hub is a fantastic initiative to try to have a collective voice of patient organizations speaking on behalf of patients with heart valve disease around the world. But there is, you know, very simply, just making noise about heart valve disease is a first step. People need to know what we're talking about when you say heart valve disease. They need to know also that it's not just a disease for which there is no possibility and no treatment, but that there's help, you know, that meaningful interventions that can really make a difference exist, but that people don't have access to them either in a timely way or an appropriate way, or they're just not available, or there isn't the education or whatever it is. So I think making noise, the patient community generally, making noise about and raising awareness and giving information about what this is, that it's treatable, and highlighting also, I think, the needs of patients that go beyond just receiving an intervention, the need for patient support, for example, through the heart teams, even through follow-up on their whole journey is really important. And, you know, if you have a patient voice, then you build advocacy at a policy level. I think also having at an individual patient level, I think, again, it's this goal of shared decision making. It implies that you have a patient who is engaged, knowledgeable, and feels confident enough to have that discussion with their physician, which we should not, and I'm not being patronizing at all, we should not take it for granted that every single patient feels ready to have that conversation with their physician about shared decision making. You're in a vulnerable position when you're in a patient. So hopefully, again, I think, or, you know, the patient-friendly guidelines, you know, the heart valve patient journey can empower patients to take on that role.
Thank you, Suzanne. Very interesting insight. Ruggiero, any thoughts from your side in Italy, the patient's role?
Yes, I think that what the patient should be aware of the heart valve disease, not at the moment that they encounter the problem. Okay, so usually people with heart valve disease, they start to, you know, get knowledge of what they have the moment that they have diagnosed some form of heart valve disease. I think the important step is to make people aware of heart valve disease, even if they are not have heart valve disease. That is the important step. So because the moment that people get this diagnosis with heart valve disease, they immediately go to a physician, you know, and probably they make a decision how to solve the problem in the wrong way, because they think, oh, I have the problem, I have to solve the problem, and the first suggestion is taken, and this is so. If you already are aware what is heart valve disease, what does it mean? It can be asymptomatic for a long period of time, and then at the moment you start to have the symptoms, maybe it's too late. So you have to do some echo every 6 months or every 1 year. So knowing this problem before, on a general term, I think is the important step of the campaign to increase awareness of the people. Not only, because usually only people that have a heart valve disease know something about heart valve disease.
Exactly.
That is a mistake. Everybody knows about the cancer if they don't have cancer, more or less. Now everybody knows about the viruses, even if they don't get the COVID. So it's the same for heart valve disease, because people don't think how frequent is heart valve disease, how many people are with this problem, among us. And this is we have to, our efforts should go.
Yeah, so once again, massive awareness raising campaigns across the general population. Philippe, what are your views, please?
I think, you know, the role of the patient is very important. It's very important. I think it's, you know, the patient advocacy organization in heart valve disease are relatively new and recent, right? In cancer, we have had, you know, patient advocacy organization for a long time, and they are very powerful. So our patient organization are relatively young, but they are growing fast. And my recommendation and my hope that would be that many more patients join this organization, because we need this power, we need this lobby from the patient. This is the most powerful lobby that we can get when it comes from the patient, because these are really the patients who are impacted by this valve disease the most, you know, and they are the people who are the most passionate about trying to improve their journey, right? And I can tell you that when we developed a little story, but when we developed this report, we had 4 people with lived experience participating to this report, and they were the most critical and demanding. And you Nicola, you mentioned that you like, you know, those milestones that we put, you know, by 2025, by 2030, this needs to be accomplished. This was a will of the patient. Actually, in the initial version of the report, this was not there. And the patient were feeling that, hey, this is too vague. This is not specific. This is not, you know, and we need more to be more precise. We need to put more pressure. And in all the other, I'm optimistic also because I see that we listen to the patient now. You know, in every initiative I see, and I'm involved in the academic, all the academic research consortium, like the one about tricuspid valve, etc. And we started with process by doing interviews of patients. And what is important for them? What are the outcomes that are important for them? Because the outcomes that are important for the investigators, we think about what we call the hard endpoints, like mortality, hospitalization, stroke. But this is, of course, this is important for the patient. But for the patient, what is most important is the quality of life and things that maybe we are not enough aware, the investigators. And so these interviews were very powerful. And actually now we're redesigning completely the endpoints for tricuspid valve intervention centered for the patient. We need to use centered, patient-centered outcomes and endpoints. And I think that only the patient can tell us what we need to look at. So I think we should not underestimate their role. It's extremely important.
Thank you very much for that, Philippe. And I think the whole area of patient-relevant outcomes, looking at the goals that matter to patients, is taking on more and more attention in many different disease areas. You mentioned that the heart valve disease community is relatively young. The patient organisations are quite young, but I think that there is an opportunity perhaps for them to fast track and leapfrog and learn from the experience of other organisations in the cardiovascular disease space and potentially beyond that. We have a couple of other really key questions coming in. One to the 2 professors, I think. Are there any differences between men and women when it comes to valve disease? I'm asking this as historically men have been the default prototype for CVD. Is there any advice you can provide to men and women on how to identify valve disease or any CVD generally speaking? And I'd go to Philippe on that one to start with, please. Back to you, Philippe.
No, I think it's extremely important question, and this has been addressed in our patient journey report. We have a box in the report that is specific on differences between women and men. I think what we have experienced with other diseases is unfortunately true also for heart valve disease. Often heart valve disease are less detected in women than in men, and once they are detected, women are often referred later in the course of the disease to intervention. So they come to intervention with often more advanced disease. And as we discussed with Regurgitation before, there is now evidence that if you intervene earlier in the course of the disease, you will have better outcomes, better results. So if you are referred later, so women are referred later, you may have worse outcomes than men. So this is an issue. And I think we need more research, we need more data in women. Women are often also underrepresented in the clinical trials. For example, the low-risk trial in Italy, 70% were men, only 30% were women. So we need more data, we need more research for women, and this is something that people are now more aware. And this is why there are some randomized trials now ongoing in TAVI, where it's only women who are included, to kind of compensate for the lack of data that we have. So I think this is an important issue, and we need to pay attention to that. And there are some people doing research specifically on. We have a chair here in our institution which is dedicated to women heart valve health. So really dedicated to valvular disease in women. So it's coming. So again, I'm optimistic on this front, but we have a lot of work to do.
Thank you for that, Philippe. Ruggero, do you have anything to add here from your perspective?
It is true what Philippe just mentioned, because we know, for instance, that the result for coronary disease, operation for coronary disease, are worse in female as compared to male, and is probably the same is true in the case of, for instance, what Philippe was mentioning for aortic stenosis. And then we don't know there is exactly, it was for some anatomical factor, but also because they came late having the diagnosis, and so the treatment came late in the problem of disease. So that's why is more research needed. But for sure there is some differences between male and female in this respect. So we have to research more in this field. Yeah, I agree.
Thank you, Ruggero. Another question that is broadly around shared decision-making, and I think there are two questions that I'll try and bring together. Shared decision-making is inherent to both the patient journey report and the guidelines. How do we translate that in practical terms? And then a more specific question here, how should we communicate complex patient outcome data when patients want new therapies that are difficult to access? This is where shared decision-making is crucial. Any thoughts from the panel on this? And I'll go to Suzanne to kick off with those two aspects, two questions more or less in one. Shared decision-making, how do we translate that into practice? And then when we're looking at something very specific, innovations that are quite complex and difficult to access, any advice, any thoughts? To you, Suzanne, and then we'll do a round of the table, the virtual table. Please, the floor is yours.
I think something that we haven't mentioned actually is the role of patient organizations for patients. We've spoken about them as an important advocacy group to try to change things, and Philippe spoke very passionately about that. But I think, and the whole COVID pandemic has demonstrated that patient organizations can be absolutely invaluable sources of help and support and information for patients. And I think, and they can be a lifeline for them, in fact. And I think that the role of patient organizations, a really important one, is to give information in a way that is accessible to other patients and through peer discussions and learning, so that they can then, again, bring that information into their decisions, into their communications with their individual physicians. So that's on the patient side. I think on the doctor side, it's about training. It's about making shared decision making an integral part of the medical curriculum, teaching communication skills, and most medical schools have that. I mean, I'm sure there are more steps to be made. There are shared decision-making aids in the form of various digital tools or others, and some may have their opinions about those or not. I'd be interested to hear what Philippe and Ruggero think. But I think it is a shift in mindset also on the part of, not all physicians probably think that shared decision making or know how to actually embrace shared decision making potentially. They're also, clinicians are usually not exactly in a situation where they have tons of time on their hands when they're with an individual patient. So I think providing training, building it into ward rounds, medical curriculum, and really, I think empowering physicians to adopt this way of communicating with their patients is really important. I think something that I don't like, which I see a lot in the literature, is, that doctors don't like doing shared decision making. Well, I think one has to recognize it's, I think that this is a potentially new way of working between patients and physicians. There may be barriers on both sides. Some barriers that one is aware of and some not. And I think it's a question of both having the confidence to have that rapport and to try to work together. And on your second point, I think the translation of complex information, again, that's where these kinds of documents are really important, I think. And we can't just take it for granted that just because something's written in the guideline, everyone's going to understand what it means. And I would say even that the medical profession understands what it means. And particularly if you think of, if you need a GP or a primary care physician who doesn't only treat patients with heart valve disease, but a million other conditions, how do they get to understand innovation as it's coming very, very rapidly through the pipeline? There's always that need for translation to whatever the language is that's going to be accessible to the person who needs it.
Great, thank you, Suzanne. Philippe, thoughts from your side?
Well, I think, to enable true, efficient shared decision making, first, I think the patient needs to be well informed about the disease, about the option for treatment, etc. So I agree with Suzanne. I think this is here where the patient advocacy organization have a role to play to provide the right information to the patient in a lay language and do the type of thing that we are doing today. For example, this type of webinar is meant to inform the healthcare professional, but more importantly, the patients. And I think at the level of Heart Valve Canada and the other Heart Valve Voice have done this as well. There are some webinars that are organized, dedicated to the patient and their family. We had also this idea, and other patient organizations are doing this type of thing, to do lay summary of the key articles that are published in the literature. Because if you go to, these big papers published, in New England Journal of Medicine, etc., even us, Ruggiero and I, we go through those papers, and when we read it at the end, we are a bit fatigued, and it's difficult to get some part of it. So for the patient, they read that, or they read what is in the internet, which is sometimes not clear, and they don't have the right information, or they don't really understand what is in the paper. So to have a kind of lay summary, not of all papers that comes out about valvular disease, but maybe the key ones are important. Lay summary of the guidelines, so they are better informed. So I think that's the key part. And then also maybe the patient organization could provide some flyers and some documents for the primary care, for the cardiologist, in order to facilitate this communication that we need to have between the heart valve clinic, the heart team, and the patient. And the heart valve clinic and the heart team, they also have to do this effort to communicate with the patient in a lay format. It depends who you have in front of you, but you have to explain the information in simple terms, and some document may help in this regard. So if they have kind of pre-prepared document, for example, about the care and follow-up after an intervention, some patient organization have prepared some flyers for that to help the healthcare professional. That might be another interesting direction we can help.
Thank you, Philippe. I think that's, again, pointing to the major role that patient organizations can play, but of course they need properly resourced for that to happen. Ruggiero, please, any comments from your side on shared decision-making in this specific question on communicating complexity, very difficult to access new technology or innovation?
Yes, disseminating the knowledge is the key point, because I want to point out the difference in sharing the decision with the patient if the patient is already aware. Let's say it's a simple decision making. What type of valve prosthesis you want? You want a mechanical valve or a biological valve? Just a simple choice is completely different if the patient is already aware. The type of question you get from the patient that is already informed are completely different from the guy that all of a sudden he has to decide, what type of surgery you want to have, minimally, non-minimally, what type of valve do you want to have altogether. So it's impossible for this patient in a short period of time to take all decision. And so they are unable really to share your decision with the doctor. When they are informed, the sharing decision-making process is much easier, and also is more profitable for both for the doctor, is able better to explain, to go more deeper into the details of the choice of the patient, and also, of course, for the patient, because he exactly gets what he will discover, let's say, 1 year down the road, because often he discover later what was his choice. Oh, I could have chosen differently, but that is too late. So it's very important. And this is only by disseminating knowledge before. And as to the new technology, this is even more important. Not only to explain what new technology is, but also to have access. That's why we need the patient support, because new technology are very costly. And so the access of new technology sometimes may be based more on cost than on really scientific data. So we really have to avoid this. In order to avoid this, we need the support of the patient advocacy for the policymaker, because that is very important.
Very clear. Thank you, Rodrigo. Just coming back to the heart team, we have a question here about the fact that a multidisciplinary team to support the patient in their journey is key. But what about smaller healthcare centres and hospitals, for example, in rural areas? And this also points to something that was brought up in terms of how do you reach and how do you really support patients, people who are perhaps vulnerable to social exclusion. Any thoughts about that? What advice would you give to patients who are traveling, who are trying to navigate a much more fragmented system because of low levels of health literacy, or simply because they're living in a very rural environment and the notion of a health team just doesn't exist in that environment? Rodrigo, can I come back to you, please?
To me?
Yes.
Oh,
yes,
sorry.
to you. Sorry. Yes.
Yes, I think the answer to this is a networking. Is very important. This COVID pandemic has improved a lot the way we communicate. Like now, we are doing this webinar in very nice way. The people profit most from this webinar. It's the same. So we, even from the most extreme rural area, we can help these people by networking with another heart team, with the heart valve clinic. So building a networking is also the next step. So even if you are in a remote place of the country, they still have the same access in the big city with the best heart valve clinic. I think that the solution of this problem is just networking, organize, and this is already existing, but we have to implement, and now we have the technology to do it in a very easy and quick way. So
Great,
this is the solution to this.
Thank you. So the solution is new technology. Philippe, what are your views, particularly thinking about certain communities in Canada?
Yeah, so yes, I mean, this problem is huge in Canada, because we have a very large country with a population that is not that large, so the density, so the population is distributed all over the place, more in the south, but still in the north. We have some, very remote places. For example, our hospital, we are covering a population that is about 2.5 million, but that is spread over more than 1,000 kilometers. And some people need to do 1 to 2 hours of flight to get to our hospital. So I think, heart team is one thing. The heart team is generally a multidisciplinary team that is more in the tertiary referral center. And the role of the heart team is more to take shared decision again when you have at the point where you need an intervention, and you will not find this heart team in some remote places. What we are talking more is about the heart valve clinics. The heart valve clinics, we need to have them almost everywhere, even in the very remote areas. But it doesn't need to be, because we have often a bias toward physician. We don't need to be. You can have different level of heart valve clinics with, cardiologists, etc., nurses. But it could be a nurse with a person who is able to do an echo, sonographer, and that's it. And then the rest of it could be done, the reading, the consulting, could be done remotely. We have learned with COVID how to do a virtual visit and virtual consultation. We can do that for heart valve disease as well. And I think these new technologies and new approach could help, to better serve the very remote and rural areas in this regard.
Great, thank you very much. Suzanne, last word to you. Could you give us some thoughts and perhaps build on some of the points that Regurgitation and Philip have put together?
On access to
rural in rural communities, but also perhaps access for people who are vulnerable to social exclusion for whatever reason.
Well, I don't know if I can add much to what both of them have said, but I think the capabilities that we have, not through complex technologies, but to create networks and sharing, have really been amplified and put to the fore and to the test in the last year. And I just hope that there can be an acceleration of those. I think also, again, it's a question of getting into the system. Once a person is in the system, keeping on the technology route, I think there are digital monitoring and other devices or tools that can be very helpful to enable a constant communication between the care team wherever they're based and the patient, even if the patient is in a socially excluded from a geographic perspective. If a person is socially excluded, I would say for social reasons, or more vulnerable from that perspective, living on their own, whatever there is. Again, I think the role of networking with patient organizations, which again don't have to be in their local community, and even through peer-to-peer support online, can be invaluable. Again, it assumes that someone has a connection to the internet, which is not a given for everyone. But I think that's also evolving in all countries.
Great, thank you. Look, we're coming to the end of our session, sadly, because we've got a number of other really interesting questions, but that's maybe for another summit, another webinar. Before we close and I give a little bit of information on what's happening next, I would just like to invite each of you just to think a little bit about one final takeaway message to give to our audience today, something that they can really take away and think about moving forward. And I'll kick off perhaps with Philippe to start with.
Well, I think I will
very briefly.
I will stay on the important role of patient. You, the patient, I think, please help us to help you and join this patient advocacy organization. And send us your question, your concern, your criticism, I think, and help us to lobby for better awareness and better care of valvular disease.
Very clear message. Ruggiero, please. You're on mute.
I will just join Philippe on this, so asking the patient to bring this journey, this patient journey to a next level, to bring it at the level where we can show to the media, use any type of social media or even TV show in order to enlarge the number of people they can access to this knowledge. We need to show to people that heart valve disease is a kind of pandemic, or it will be in the next year.
Yes, you used that term earlier. Thank you very much. Absolutely. Suzanne, please, very briefly now. We've got about 30-40 seconds for you.
Well, I'd build on what Philippe and Ruggiero have said, but also I would advocate that patient advocacy groups should work with professional societies and others, because there's, in as much as the voice of the patient is critical, it's even stronger if united with the voice of healthcare professionals. And I really do think there is a common will to change things for the better of patients.
Fantastic. Very, very clear messages. Thank you all very much for your excellent and thoughtful contributions today. I know I learned a great deal from all of you, and I hope the audience did as well. And thank you all for your very thought-provoking questions as well. Sorry we didn't get to all of them, but I think you've got a wealth of information from today's session. We're now going to have a break of 20 minutes. During the break, perhaps you can go to the Just One Thing tab that's on the screen right now and add your thoughts on what's inspired you, what you'll share with your community, and what you will act upon moving forward. This is really important. It inspires other participants, other members of the audience, speakers and panelists, and also helps the Global Heart Hub to shape next session's future summits. It would also be great if you would like to go back to the agenda tab and enjoy some meditation or perhaps light exercise to get refreshed for the next session, where we'll explore digital transformation and how this will undoubtedly impact the cardiovascular community. Please do come back at 16:40 CET time, sharp, because there's a lot to do in this next session, i.e. 20 minutes from now. So it remains me to say thank you all once again. Enjoy your break and see you later. Thank you very much.